Hello, everyone. Welcome to our ICARE Genetics Case Conference for May. I'm Tua Pal, and I'll just walk you through a few housekeeping slides and then go on to a case and introduce our preeminent guest speaker. So just in terms of ICARE referral, we've tried to make it as easy as possible. So we thank all of you for referring to our registry either online or through prepaid postcards that we can send you as well. We really appreciate when our colleagues submit cases for presentation. So again, we've tried to make it as easy as possible, and there is a link that I've reflected here in the slide. Just in terms of ICARE resources, as everyone knows, we host these monthly virtual case conferences. We have these biannual newsletters that we put out both in the spring and the fall with updates. Our website has resources that are searchable, and we are active on social media. And again, we are on your social media platform of choice, where we publicize talks, newsletters, open studies, educational stories, research updates, as well as guideline updates. Again, this is the last time you're going to be seeing this because this is one of my favorite conferences ever. It's the BRCA HBOC conference that's going to take place next week, May 6th to 9th. That is primarily organized by my colleague, Dr. Will Fowkes. Again, attendance, they're still taking registrants, I think. Here's the website, brcasymposium.ca, and you can either attend virtually or in person. And actually, our guest expert will be one of the preeminent speakers at this conference as well. So again, anyone that's interested, please look into it. Just a reminder, we released our ICARE newsletter just last month, and it is available on our website as well. And with that, I'm going to get started, and then I'm going to introduce our guest speaker. So here's the first case. As everyone knows, this is a case conference focused on CanRisk, both use of it as well as some exciting updates that have been made to it. So here's a 23-year-old female tested following a BRCA1 mutation identified in her mother following the diagnosis of peritoneal cancer. So you see here, mother, this is the 23-year-old. She's, again, at age 23, she's going to be too early for cancer risk management. And we did a CanRisk on her. And here are the estimates. So again, these estimates, lifetime risk of breast cancer was approaching, 77.9, so almost 80%. And then estimated ovarian cancer risk was close to 50%, which again, I thought was on the high side. I know it's years that some, like the age at which someone is going forward, that might have raised the risk, but I wanted to run this past our guest expert. So again, going through you know what, I wanted to introduce you, Antonis, but the slide to introduce you is later. So I'm going to let you comment on the case first, and then I will, again, I'm talking about someone who needs no introduction, Dr. Antonis Antoniou, who is the one who led the development of CanRisk. So Antonis, welcome your thoughts on this case.
Great. Thank you, Tuya. It's great to be here. So I assume we are doing the cases first and then the updates here on the...
Yes, so we just usually start with the first case to set the scene.
Okay, I see.
And then we'll go into
Sure.
presentation.
Yes, so let me just... so I thought I should comment on two aspects here. First, the breast cancer risk, and then the ovarian cancer risk. So, so if you consider an average BRCA1 mutation carrier in the US based on the most recent incidences, the average risk for someone at an equivalent age here will be around 76%, which is more or less similar to what you get here with CanRisk. But there's a couple of things that I think is worth considering. First of all, on how data are input in CanRisk. So a couple of things that I noticed seeing the reports that come out of CanRisk compared to the actual pedigrees, there are some differences, in particular with the way how unaffected individuals are input into CanRisk. So one important aspect to keep in mind here, because this is a genetic model, it considers information on unaffected individuals, but to consider that information, you need to input information on age and so on. So for example, information on the aunt would not be considered here, the fact that in CanRisk, the fact that she was unaffected, or information on the cousins. So if by definition we are entering only information on unaffected of relatives, then the risk is likely to be somewhat increased compared to when you add also the information on unaffected relatives. So that's the first point that I wanted to make here. The other, of course, is that there are other individual risk factors that are included for this individual, the lifestyle hormonal risk factors. So this particular carrier has also has used oral contraceptives, is nulliparous. She's very young, of course, but if we enter that she's nulliparous at this stage, it will affect the long-term risk. And also the BMI was greater than 30, which can be risk increasing category in the at least from age 50 onwards. And then there is the additional history of in the family of breast cancer. Kind of one thing to remember is that risks for carriers are not constant, but rather they are modified by family history of the disease as well. Now, another aspect to say, the risks in BRCA1 and BRCA2 carriers have been validated in a study that was published last year. So there was a prospective cohort of BRCA1 and BRCA2 carriers. So we validated the 5-year risk at least. One aspect to consider is that at this stage, where it's not possible to validate lifetime risk, and this individual is age. If the concern is with the lifetime risk that is predicted by CanRisk, we don't have the data at this stage to validate such risks prospectively. Then, if we look at the ovarian cancer risk, which I thought it was interesting here. So here, the average risk for an equivalent carrier that age based on the BRCA1 incidences in CanRisk would be around 31%, which is lower compared to what you get here. But there are, again, kind of a number of explanations here. So again, there are the differences in the fact that we are not considering the unaffected individuals, but also the risks in of ovarian cancer are modified by the family history of the disease. They are not fixed just because someone is a BRCA1 carrier. The risk will vary depending on family history as well, because those mutations don't explain all the familial aggregation of ovarian cancer. So in this case, the fact that she has a mother and a great-grandmother diagnosed with ovarian cancer, based on epidemiological data, for example, that we published back in 2017 in a prospective cohort of BRCA1 and 2 carriers, we see that the ovarian cancer risks in carriers are also modified by the number of first and second degree relatives that someone has. So if you look at the bottom line of this table, someone with 2 affected first or second degree relatives has a hazard ratio of around 1.8, and the risks, in fact, are greater compared to not having family history of ovarian cancer. So the 45% for example, here is in line with what someone gets from CanRisk here. So epidemiologically, they make sense. And the last point for this case, I noticed in the report that, again, this individual was indicated as nulliparous. Of course, at this stage, if you're concerned with the long-term risk, you may want to consider that they may have children later on, which, of course, based on the model, it will bring the risks down. So if instead someone indicates this individual as instead of nulliparous having parity unknown, the risks will be lower. It will be around 42%. So it depends on how you treat also the risk factor information. So I think that's, yeah.
No, that's super helpful. And I'm just going to tell you, so with the pedigree drawing, sometimes I think all of us get, like, we're just trying to put in the information that's easiest that we think are relevant. So I think the point that you bring up, that by being lazy, because I can tell you I inputted this and I just, I figured out which ones I thought were going to be important. But you bring up a really good point. I guess we are going to have to be more comprehensive, which again, as you know, takes a lot more time in the context of
Absolutely, yeah.
being a patient. But again, figuring that out, because that is going to be important, is what you're telling us in terms of.
Yeah, you
And,
may want to, if you're inputting only affected individuals, you may consider those as kind of like an upper bound.
but can I ask you, if we know it's coming from one side versus the other, what you're telling us is we should still input the side that the mutation is not coming from, is that?
Absolutely, because the way that these are genetic models, so they take inheritance patterns from both sides and they model the entire familial risk. So polygenic inheritance, for example, doesn't come down; it's not inherited just from one branch of the families. So of course, kind of both sides will influence risk. Yeah.
No, I mean, it was instructive to me to see your slides. So I will certainly do a better job, or try to do a better job. So let me go. I'm not seeing any questions. So I'm going to go on to introduce you now. As everyone knows, this is we're thrilled to welcome Dr. Antoniou as our guest expert today. He's professor of Cancer Risk Prediction, Center for Cancer Genetic Epidemiology at the University of Cambridge, director of the Cancer Data-Driven Detection National Strategic Initiative. And again, as many of you know, his main research focus is development and application of statistical modeling techniques to address clinical questions and develop risk prediction tools for use in clinical practice. And that is the focus of today's talk. And he's led the development of CanRisk. So Antonis, take it away. We're excited to hear what you have to say.
Great. Thank you, Toya. So I think I spoke to this forum maybe a couple of years ago. So what I thought I would do, rather than describing CanRisk from scratch again, is focus on some of the most recent developments that took place over the last couple of years. So primarily the adaptation of the models to ethnically diverse populations, incorporating continuous measures of mammographic density, and the forthcoming prostate cancer tool. So just to recap, so the CanRisk can be used to predict currently the risks of developing breast and ovarian cancer on the basis of the combined effects of rare genetic variants, the polygenic scores that describe the effects of common genetic variants, lifestyle and hormonal risk factors, mammographic density in the case of breast cancer, cancer family history. It takes into account tumor pathology information, and then these are all combined with cancer incidences to provide the personalized cancer risks. But one of the challenges until recently has been the lack of data on women that come from diverse ancestries. So most of the data that we have available came from women of European ancestry or white ethnicity, but data are now becoming available. So on those populations. So what we have been focusing in the last couple of years is extending these models to kind of ethnically diverse populations. One of the challenges here is that the ethnic makeup, of course, varies across different countries. So it's unique across countries. So which adds complication in extending this across every country. So we have been working on developing the necessary methodology, which will allow us to do that. And we started with UK as an exemplar, but kind of this can be extended to other countries. So what we are doing here now, we consider two concepts. First of all, is the self-reported ethnicity. this is more of a social construct. So we use the self-reported ethnicity to describe the lifestyle and hormonal risk factors in the model, and we use the categories in the UK at least that are collected by the government based on the census. And then we use the genetic ancestry, which is determined using genetic data and is derived statistically to model the genetic components of the model, so the rare genetic variants and the polygenic scores. So just to describe how we customized each of the model components, starting with the cancer incidences, we use data from NHS England. That's kind of the cancer registries here in the UK to derive the cancer incidences for each ethnic group. And this example here shows the breast cancer incidences for the different ethnic groups. So you can see on the top with the khaki green colored line curve that the incidence is highest among white women, but the incidences are lower for Black and Asian women, shown in green and blue here. As I mentioned earlier, the models include also the tumor subtype information, in particular around the ER status, triple negative status. So here we used data again from the National Cancer Registration dataset to estimate those distributions for the different ethnic groups. And these graphs here show, as an example, the distributions of estrogen receptor positive tumors by the age at diagnosis on the x-axis by the different ethnic groups. So what you can see, for example, is that white women tend to develop primarily estrogen receptor positive breast cancers, whereas the likelihood of developing ER negative tumors is greater among Black women. So something that we knew already, but now they're incorporated explicitly into the models. So the next component in the models are the rare genetic variants. So as you know, in the case of breast cancer, for example, we modeled the associations of pathogenic variants in 8 genes, and we now have several studies that reported those associations across different women of different ancestry. And there's a kind of a broad summary here of some of those studies. And what you can see is that the relative risk estimates actually are very similar, that we didn't detect significant differences in the relative risks of those genetic variants across the different ancestral groups. So the main assumption that we are making in the models is that the relative risks remain the same across ancestries. Similarly, we've done a kind of an investigation of the frequencies of these variants. Again, we don't see significant differences between the main ancestry groups, with the exception of CHEK2, because of the 1100 del C variant, which is much more frequent in Northern European populations. So that's unadjusted in the case of non-Europeans. But although the relative risks are the same, the absolute risks of developing cancer, though, will differ by ethnicity, because we assume different baseline incidences for each ethnic groups. And I'll demonstrate this with a couple of examples. So here, in the case of a BRCA1 pathogenic variant carrier, as you can see, the risk is around 75%. That's lifetime risk for those of European ancestry, compared to 64% for those who are of Asian ancestry. And similarly, for a CHEK2 pathogenic variant carrier, the risk will be around 24% for those of European ancestry, and for those of CHEK2 carriers with of Asian ancestry, the risk is around 17%. So, for example, in the UK, where the the threshold for defining someone as at moderate risk of developing breast cancer is 17%, an Asian CHEK2 carrier will only just make it. The component where we know that there are clear differences in the in prediction are the polygenic scores, differences by ethnicity. I mean, kind of are the polygenic scores. So the default polygenic scores that we include in the model, the 313-step PRS, was developed and validated using data on European ancestry, which you can see on the top row here. But when those have been investigated in in women of different ancestries, what we see is that they are clearly predictive of breast cancer risk as well, but with attenuated effect sizes. So you can see the odds ratio, for example, among African ancestry women is around 1.27 compared to 1.61 in European ancestry women. So these are now incorporated into, these differences are incorporated into the models. So the way that we do that here is by adjusting this alpha parameter. Those of you who may have used the polygenic scores would know about this parameter. It describes the percent of the familial risk that is explained by the polygenic score. So you can see that this is lowest among the African ancestry women, which describes this lower predictive ability of the PRS among this group of women. And then we also take into account the differences in the distributions of the polygenic scores, which you can see on the left-hand side plots. So we can see, for example, that the mean PRS is lowest among European ancestry women, but highest among African and East Asian ancestry women. And these differences are important because when we come to input these PRSs in the model, we need to calculate the standardized score, the Z scores, and we need the mean and the standard deviations. So these are used here. I should say that, of course, CanRisk allows for arbitrary polygenic scores to be used as well. So if we have multi-ancestry polygenic scores or polygenic scores which have been shown to perform much better in different ancestry groups, those can also be used as long as we define the relevant parameters. And the last component in the customization are the lifestyle and hormonal risk factors. Again, a systematic review that was published last year demonstrated that the relative risks of the different risk factors do not vary significantly across different ethnic groups, but what is different are the distributions of those risk factors. So, for example, the distribution of parity, the distribution of BMI. So here we use ethnicity-specific distributions that we derive from surveillance data in the UK. So having defined now these models, these have, of course, implications for risk stratification, and I will try to demonstrate here the implications of risk stratification by ethnic group using these graphs. So what we are doing in this graph, we are predicting the breast cancer risk by age 80. This is what you see on the x-axis here. And the shaded regions in the graphs show the 3 risk categories as defined by the NICE guidelines. So high risk, for example, are women who have risks of 30% or greater. That's the UK guidelines. And the red curve here shows the distribution of risk based on the multifactorial model among European ancestry women. So what we see with the area under the curve for those who fall into the moderate and high risk category is around 20%. So this is saying that based on the multifactorial model, we can identify around 20% of women who fall into the moderate or high risk groups using the models. Now, if we plot the same distributions for African ancestry or Asian ancestry women, you can see that those curves are shifted towards having a lower risk, but also they are narrower in terms of the distribution. This is because of the lower cancer incidences in those groups, but also the lower predictive ability of the PRS. And now if we classify this into moderate and high risk groups, as you can see among the African ancestry and East Asian ancestry and Asian ancestry women, we would only be identifying around 5% of those based on the multifactorial model who fall into the moderate or high risk groups. So a much lower proportion. So I think one of the implications here, in particular for policymakers, is whether the existing risk thresholds are actually appropriate for all ethnic groups. I should say that this work is available on Meta Archives for anyone who wants to read about the methodological work, and the paper has just been accepted for publication. So this is now available on the CanRisk tool. So if someone, for example, indicates UK to be the country, it's possible to select the self-reported ethnicity. And then the genetic ancestry is input through the polygenic score menu. And there is a list of custom ethnicity-specific polygenic scores available. The other change that we implemented recently is the inclusion of continuous measures of mammographic density. This was done in order to, because at the moment we only consider BIRATs, which requires a manual reading of mammograms, whereas continuous measures are more amenable to scaling, kind of including density at population level. So we used data from the KARMA mammography screening cohort that had information also on Volpara, which is a volumetric measure of density, and also Stratus, which is an AI-based approach of measuring density, but they are continuous measures of density, which have been shown to be stronger predictors of breast cancer risk. So we used this study to develop and validate the model. So we estimated the relevant parameters. I'm not going to go into too much detail here, but other than say, when we validate the model, we see that there is significant reclassification of women compared to using BIRAT. So for example, around 25% of women, when we're using Stratus or Volpara, get reclassified into a lower or higher risk category. But in general, the changes in the risks appear to be moving in the right direction, where we see, for example, an increase in the AUC, the discriminative ability of the model, being 2 to 3% higher using these continuous measures of density compared to using BIRATs. And then this is also available now on the tool. You can select the approach that density was measured. One of the limitations here is that the data that we've had so far were primarily on women of white ethnicity. So the Volpara and Stratus have not been configured for all the ethnic groups at this stage. And then the final update is the incorporation of the prostate cancer model, which we published a couple of years ago. So this work will be, so the tool will be updated later this month or by early June to enable the prediction of prostate cancer risks also in males. So just to give you a brief overview of that model, so the prediction here will be based on the basis of rare genetic variants, polygenic scores, family history, and the cancer incidences. We don't have established lifestyle or other risk factors, epidemiological risk factors for prostate cancer at this stage. So the model includes the effects of BRCA2, HOXP13, BRCA1. We know more recently that variants in CHEK2 and ATM have been associated with prostate cancer risk as well, but these are in the pipeline. They will not be included in the first release. So just to give you an idea of the type of risks that the average risks that are included in the model. So for example, in the case of BRCA2, the average risk by age 85 is around 52%. For heterozygote carriers of the HOXP13 variant, around 38%. And then we include also the polygenic scores. It includes the latest polygenic score that was published in the literature that accounts for about 27% of the familial prostate cancer polygenic component. And then briefly to say that this model has been externally validated in UK Biobank in around 170,000 men, showing good discriminative ability with a C-index of around 77% and good calibration, where the observed risks were in line with the predicted risks in different risk categories. So in the forthcoming release, which hopefully will be in a month or so, whenever you select now a male to be the index individual, the tool will also produce the prostate cancer risks in the usual format that it produces the ovarian and breast cancer risks. Kind of different ways of presenting the risk information. And you can see an example here with a male who has an affected father, where kind of it predicts the risk of developing prostate cancer. And I think I will just acknowledge, of course, the entire team. This is not just my work, but a team in particular, the CanRisk group here that have been working on developing all this work, and our funders. So thank you.
Thank you. That was fantastic. I have some questions, but I'm going to just focus on the questions I'm seeing in the chat. So think I know the answer to this, but here's a question. Here, year of birth, especially when family is deceased, I tend to do some quick math to make great grandma, for instance, 20 plus years younger than the grandma, just to get the model run. That's what I do too. So would
I
love
think
to
that's
make sure
perfectly
that
that's perfectly fine. It's not going to make a huge difference there. I think you only need to enter the year, an approximate year of birth. I think it's very similar within even an interval of kind of 10 years plus or minus. They're not going to vary much. This is just to ensure to capture the right incidences in the model. So inputting approximate years of birth, it's fine in the model.
Okay, and this is another question that came up in my head as well. So pulling up the paper now, using the model in the US, I see the caveat that it assumes white European population. For my non-white patients, should I stick with that or choose UK model and then ethnicity, or are neither appropriate? Because this happened to me yesterday when I saw a black PALB2 carrier and I couldn't input that piece. But yeah, I would love your thoughts on that.
Yeah, I think, yeah, I mean, ideally, we want to incorporate the US incidences because there could be some variation in the incidences for the different ethnic groups in the US compared to UK. I think kind of there could be, for example, higher compared to the UK for Black or Asian in certain age groups. So this is something that it's important to keep in mind. If you're using polygenic scores, though, I would say, and you have information on genetic ancestry, I think it may be better that you use the tool will still allow you, even if you are in the US, you can still select different genetic ancestries for the polygenic scores because we know that there's a big difference there and kind of in the effect of the polygenic scores across different genetic ancestries. So if that's available, I would say even if approximate, I think it would be much better to use the customized tool for the different ancestries.
Okay, so most of us are not using Ancestry right now because we're not using PRS yet.
Okay.
So that's why, like, I guess the bottom line is either we say the person's from the UK so we can fill in the ancestry, like what race they are. Like, do you have a sense of what might be better for us to do within the confines of the tool right now in the US population?
Yeah, I guess what we haven't done and I haven't got a good sense of is the exact differences. It may be worth actually looking at the exact differences in the cancer incidences between Black women, for example, in the US and Black women in the UK. If there are big differences in those, then I think you may be a bit cautious there. So this is something that we haven't done yet. So it's important, I think, to check that before.
And I guess we could run it both ways and see what like the variation is. That would be the
yeah.
But yeah, okay. And then another question, what if we don't know the patient's genetic ancestry, only their self-reported ancestry? Does this impact the accuracy of risk prediction?
Well, in practice, we know that actually the self-reported ethnicity and genetic ancestry are highly correlated. For example, if you look at the UK Biobank, which have both self-reported ethnicity and genetic ancestry, the correlation is almost 90% there. Where people get it wrong a lot is when it comes to mixed ancestry. So I think kind of if genetic ancestry is not available, I think you could approximate it with self-reported ethnicity there in principle.
Okay. And then there's a thank you for the prostate cancer tool that will be released soon in the chat. There's another question on the prevalence of use, which I think is probably out of scope of.
Prevalence of, sorry?
So it's the prevalence of the use of CanRisk among genetic counselors versus the use of Tyrer-Cuzick, which It's more of
Right.
a service delivery question.
Yeah, I know how many people are using CanRisk, but because we can see the number of risk calculations people do, so but we don't, I cannot compare.
Yeah, no. And from an NCCN standpoint, I mean, I think we do include verbiage on CanRisk in there, but again, NCCN definitely encourages individualized risk assessment. Here's another question. Medical oncologists often still depend on Gale 5-year risk estimates to consider chemoprevention. Tyrosine CanRisk are more inclusive. Is it now appropriate to use CanRisk scores for consideration of chemoprevention, even though it was not used in the original clinical trial for risk reducing tamoxifen? That's a great question.
Yeah, but I think I mean, the Gale model is quite old now, and there have many studies that have shown that both CanRisk and therapeutic perform much better in terms of discriminative ability. So, I mean, personally, I would say that yeah, you should be using more up-to-date models.
No, I agree. It's interesting. Okay, so we have 4 more cases, so we're gonna try and get through all of them. Our first presenter is Elise Austin from Salt Lake City. Elise, are you on? Elise?
Oh, hi, can you hear me?
Yes, I can hear you now.
Perfect.
Take it away.
Great, I was double muted. Great, yes. So what I want to present a case just from last December. This was a 50-year-old female. She was diagnosed with a right-sided breast cancer. Her pathology was invasive ductal carcinoma. It was ER/PR positive and HER2 negative. Her surgeon had ordered a 48-gene hereditary cancer panel, and it came back with a likely pathogenic variant in BARD1. She did have a maternal family history of breast cancer. Her mother is deceased, but by report had BRCA1 and BRCA2 analysis. That was negative, and then she also has a maternal aunt with breast cancer. So, myself, and actually I had a genetic counseling student with me too on this case, but so she ran a CanRisk, and to report, to have the estimate, the contralateral breast cancer risk estimate. And I was just surprised at how high it was, that it came back as, by age 80, a risk of 30%. So my question is basically, what kind of went into making that so high? Am I understanding with like BARD1 pathogenic variant carriers, we don't have too much data about contralateral risk? And this is just not related to this case at all, but I just really have been wanting to ask is what do we do about our women with DCIS who also have these rare, genetic variants, since you can't count that as like a breast cancer in the model, but I just want to make sure that goes out there because I always wondered that.
Great. Thank you, Elise. These are really great questions and questions that we get a lot on the help desk as well. I think also it's important that we clarify a couple of things on how we interpret the risk. So I'm just going to proceed the slides because I've got a couple of discussion points just to not to forget anything. So one thing to clarify, when we calculate the contralateral breast cancer risks in CanRisk, we only consider the risk of contralateral breast cancer risks to be influenced by the risk factors that we have already only in the model. So we are talking about the rare genetic variants, polygenic scores if available, family history, or the lifestyle and hormonal risk factors. In this case, of course, I should say the fact that she has one affected, the mother is affected and the aunt is affected increases the risk. So, for example, if you were to do the same calculation for a BARD1 carrier without family history, the risk would be around 24%, so lower. So the fact that it's higher in this case is because of the family history. And kind of the other issue to keep in mind is that, of course, we don't have, as you outlined, we don't have reliable risk estimates at the moment that have not been published of contralateral breast cancer for BARD1 carriers, but similar issues apply to the other genes as well. So what the model is doing is basically it makes the assumption that the contralateral breast cancer incidence is just 50% of the overall breast cancer risk in the standard model, because only one breast is at risk. So in effect, what we are doing, we are just doing a model prediction, and it's not based on external contralateral breast cancer risk estimates for those carriers. The other most important issue to keep in mind here is that in CanRisk, we are not asking information about treatment. So of course, kind of, I imagine in this case, the patient may have received hormonal therapy, chemotherapy, and so on, but we are not considering this. So, and we know that those reduce the risk of contralateral breast cancer. So it is important to consider those as an overestimate and make allowance for the possible risk reduction due to treatment. And the other issue is which is correlated to treatment as well, is the exact tumor pathology in that patient. Again, kind of that's not considered in the model. So these are aspects that we are working on. It's one of the kind of the next thing that we've started working on improving the contralateral breast cancer risk prediction by including treatment and tumor pathology information into the model. But at this stage, it's important when interpreting those risks to keep these issues in mind. Now, when it comes to the second question was on DCIS. So the advice here is that CanRisk should not be used when someone has develop DCIS in order to calculate the risk of subsequent invasive cancer. We know that DCIS, of course, is a risk factor for breast cancer, and the risk of the second invasive depends on the type and the treatment of DCIS, which are not considering at the moment, or the treatment. So again, this is work in progress. This is something that is in our current program of work, but it's not there yet. So you should be the advice is that CanRisk should not be used if there is DCIS.
Perfect. That's super helpful, because that was one of the questions in the chat. So CanRisk contralateral breast cancer risk estimates can sometimes be quite a bit higher than numbers quoted in NCCN. Can you speak to why that is the case? But I think this case kind of addresses that. And I can tell you personally, I've had some really sky high contralateral breast cancer risks as well. So it always makes you take pause. But I think there are some qualifiers here that you mentioned that we should be aware of that actually make it less of a risk.
Exactly. We know that, hormone treatment and so on, we may reduce risks up to 50% based on epidemiological data. So it's important to take those into account. But unfortunately, they're not considered in the model, but this is something that we hope to incorporate soon.
Okay, no, that's great. And even your comment about DCIS, my understanding of DCIS is certain DCIS, depending on the grade, is more important versus low risk ones. So again, that's what my oncology colleagues have started to tell me in terms of, risks for future or risks for invasive. Okay, here is another question. Can you add great-grandparents, great aunts in CanRisk? Working on a pedigree right now, and would be impactful to add some great aunts, I think.
Yeah, you can input an arbitrary pedigree with relatives as distant as you want. You can build it. If you do it manually, of course, it takes a bit of time to add very distant relatives. But in principle, one of the advantages of CanRisk is that you can input an arbitrary pedigree. We had someone anecdotally from Iceland trying to put almost the entire country on CanRisk as an upload, because of course they had huge pedigrees there, and they almost broke the servers.
Okay, and then here another question. Should we not include relatives who have had DCIS in the family history? And I think that's what you're saying, Antonis, right? We shouldn't be counting
Well,
that as breast cancer, or
well,
should.
I mean, primarily, it's predicting the risk for someone who has DCIS. It's a risk factor for someone who has DCIS. I mean, how you treat the relatives, yes, strictly speaking, no, it doesn't take that into account, but you may want to do the calculation with and without and see the risks. I know some people, at least in the UK, for example, assume the DCIs and then they add 10 years to the diagnosis in the relatives when they calculate the risk and treat it as a breast cancer, just to put some weight on the fact that a relative has had DCIS. But yeah, kind of ideally, we want to incorporate this explicitly in the models.
Okay, and then here's another question. Should we not use CanRisk for patient with LCIS and ALH, patient with history of both, and CHEK2 mutation, low risk mutation, Tyrer-Cuzick about 60%, CanRisk about 25%?
Yeah, again, that's not incorporated in the model, so in a way, it doesn't account for that. So this is something that we would like to, including history of those subtypes as well, is something that we would like to add.
Okay, I'm going to go on to the next case. I'm sure you're going to get more and more questions, but next case is a shared case between myself and my colleague, Mariah. Mariah, take it away.
Yeah, my name's Mariah Hubert. I'm a genetic counselor at the Hereditary Cancer Clinic in Vanderbilt. So I first saw this patient because she actually has a family history of her mother having both an ATM mutation and a CHEK2 mutation, with a history of breast cancer at 56. And then the patient's maternal aunt also happened to have breast cancer diagnosed at age 56, and she was also tested positive for both the ATM and the CHEK2 mutation. So interestingly, my patient tested positive for just the ATM mutation, and her cousin, the daughter of the aunt, tested positive for only the CHEK2 mutation. So she then went to meet with TUA, and through shared decision making, decided on MRIs at age 31 and 33. She's 28 now, and then annually at 35, and then mammograms annually from age 40. So we noticed this strong family history of breast cancer on her maternal side. Her maternal grandmother also had breast cancer, but did not have any genetic testing before she passed away. So we ran CanRisk on her. When I initially met with her, she had not had any type of breast imaging yet, so we didn't have mammographic density, breast density. But she just recently had a mammogram in March of 2025, so we reran it. This should be BI-RADS B, so she had the scattered areas of fibroglandular density. So she came out with a lifetime risk of 35% for breast cancer and 1.3% for ovarian cancer. So interesting case that brings up CanRisk, and does it are the risks additive of each other? And oh, might have gone too far. Yeah, so when it's calculating, are the breast cancer risks additive of each other? What are you thinking about the risks that we got for her? Does that seem, appropriate given the family history and the genetic mutation? So just wanting to hear your thoughts on this. We think that we're probably going to start seeing more cases like this where we have two mutation families.
Thank you, Brian. This is a great case study as well. I just wanted first to clarify how CanRisk deals with joint with carriers of joint mutation carriers. For example, about in this case the mother and the aunt who carry pathogenic variants in ATM and CHEK2. But first, just to the evidence so far, what we see from the literature, and these are some unpublished data from an analysis that was done more recently using the bridges sequencing data to look at the interaction effects of different rare genetic variants. So in this table, what we see here is the interaction relative risks between the various genes. And what we see is that there is clear evidence of interaction when a high risk gene is involved, so BRCA1, BRCA2, PALB2, where kind of the risks are for joint carriers of those genes in those genes, the risks are smaller than expected under the multiplicative model. But when we consider the more moderate risk variants, so ATM and CHEK2, actually the multiplicative model seems to be fitting well there. So what that is saying is that the risks multiply. So someone who carries an ATM and CHEK2 variant, the risk will be much higher compared to just carrying only one of those pathogenic variants. But unfortunately, when we developed CanRisk, this data were not available to model the joint effects. So it assumes a dominant model where basically and the order of dominance is what's shown here. So for example, if someone carries PALB2 and a CHEK2 variant, the risks that kind of are assumed in the model will be according to PALB2. And if someone carries a CHEK2 and an ATM variant, the risks will be according to the CHEK2 variant. So this, of course, means that someone with a CHEK2 and an ATM pathogenic variant may potentially have the risks underestimated in this case. So you need to consider those as potential kind of lower bounds if you have carriers of joint pathogenic variants in those low moderate risk variants. Of course, in this case, it would influence the risks only for the mother and the sister, not necessarily, and the aunt, not necessarily the index individual. So in this case, I think you obtain a risk of around 30%. So this is an ATM carrier. The average ATM risk is around 24% for someone with the same age. But of course, here you have the affected first and second degree relatives. So the risk will be higher than the average risk. So I think it seems to be in line with one would expect for an ATM carrier with the family history that you observe. So you mentioned also mammographic density. The one note of caution here. So this was a 28-year-old individual, if I'm not mistaken. So although kind of the model allows for that to input mammographic density for younger women as well, the validation data that we have so far on mammographic density is on women over age 40 because we use data from mammographic screening cohorts. So those tend to be women who are older usually. So just one note of caution when you use mammographic density in younger women. So yeah, so these will be my thoughts here.
So, the other thing that I found interesting for this one is like for the mom, for example, we don't know if her breast cancer was the result of ATM or checked. So you can't even attribute it to one or the other. But I guess, again, the model's the model, you input it. You're right. It's not going to affect our probing.
Yeah, I mean, one thing to keep in mind is that, of course, with these more moderate risk variants, there is multiple individuals diagnosed with breast cancer in the family. So it's unlikely that those will have explained all the familial aggregation.
Yeah,
so
you're right.
There is family history that would influence the risks in here.
Yeah, no, we found it an interesting case. Okay,
Yeah,
so
no,
we'll move on. We still have 2 cases left. We may go over just by a few minutes, but the next case will be presented by my colleague, Katie. And I think it's going to be along the same theme.
Yes. Yeah, very similar. So I'll go relatively quickly, but the proband was a 53-year-old who came in and was tested because her sister was diagnosed with breast cancer at 54 and tested positive for an ATM variant. And you can see the pedigree. I won't belabor it. Nobody else has been tested in the family. And when we ran her CanRisk, it came back as 42%. 0.9%, which felt really high, especially as I think a lot of us might, for me at least, if I'm disclosing results by telehealth, I'll oftentimes screenshot like NCCN guidelines to go through them with the patient. So to have kind of side by side of, a 20% range and a, 43% range felt like a big discrepancy. So we wanted to see your thoughts.
Sure. Thank you, Katie. So let's, so these are the risks that you get. So it's about 43% for breast cancer. So again, kind of this goes back to the points that I made in the first case. So I looked at the input data in the report that was sent to me as well and compared it against the actual pedigree. So if you notice, the bottom line is the bottom figure is what was entered in CanRisk, which again, it focused on entering only the affected family members. So here you have several unaffected family members who are older as well. For example, 95-year-old, 75-year-old grandmothers and so on, or the cousins, but all those were not entered in the family. So on CanRisk. So by definition, you'll be overestimating the risk because you are selectively inputting only the affected individuals in the family. So in CanRisk. So keep in mind that information, as we said earlier, on unaffected family members also matters. So then, assuming that this is what we have. So the average risk for a 53-year-old in the US with an ATM variant would be around 18.4%. So which is about it's lower than the 43% risk that you get. But that's assuming that you don't have information on family history. But of course, we know, as I mentioned earlier, that ATM cannot explain strong familial aggregation of breast cancer. So having information on the fact that they have affected relatives will influence the risk. So here there are 2 affected first-degree relatives and a second degree relative. So again, keep in mind always pathogenic carrier risks are modified by family history. And we know from epidemiological data that the familial relative risk for those with 2 affected first and second degree relatives is around 3. So 3 times more likely to develop risk compared to someone in the general population. So even if you do a back on the envelope calculation of considering the average risk of 18% for an ATM carrier and say kind of that they have this number of affected first and second degree relatives, you would get a risk of around 46%. So which is in line with what you get from CanRisk. So from that point of view, I think what you input in the data and you get from CanRisk is in line with one would expect. It's the fact that it's the family history. So, and again, kind of that risk will be somewhat lower if you had the input information on the unaffected relatives.
Okay, we're getting the message, Antonis. You can't be lazy. I know
Could I ask a question so if we hypothetically knew mom and aunt were negative and we input that into CanRisk, would that kind of drastically lower it, or would it still have that same additive effect because it's still affected relatives?
But I would say probably it may be even slightly higher because it means that the cancer
that there's an additional unaccounted for risk.
Exactly, familial risk, yes.
So strong family history is going to bump it up regardless.
Always. Always, family history modifies the cancer risks in carriers, and we've seen that with studies that have been done in BRCA1 and BRCA2 carriers with breast, ovarian cancer, and now some of the other RAF51C and D. The penetrant studies have demonstrated that already.
Okay, thank you so much.
Okay, I'm going to rush through our last case, which is a case that I saw. 61-year-old female patient was tested because of this family history of breast cancer. Mother and sister with breast cancer are not yet tested, so we don't know which side of the family it's coming from. And the patient, unaffected patient, has a PALB2 mutation. So ran the CanRisks, and you can see here again. kind of on the highish side is what my thought was for PAL-B2, and then super duper low for ovarian cancer, which again, I think you've explained to us before that sometimes when the breast is high, the ovaries are low because of some of the risk factors that go in different directions, but would love your input on this one.
So again, I guess sometimes in questions that we get, it's important to distinguish with the average risks that are that have been reported for those pathogenic variant carriers, which usually kind of is over possible family histories and kind of how the risks is modified by family history. So here again, kind of there's the same issue. I'll not elaborate too much that the fact that there's some of the unaffected were not input. Now, if you take the average risk of a PAL-B2 carrier who is 61 years old to age 80, will be 30% in this case, compared to 54% that you get from CanRisk. But again, you have two affected first-degree relatives in this instance, the mother and the sister. So again, if you do that back on the envelope calculation to get kind of see whether the model is giving the right answer or not, you would get a risk of around 59%. So the two affected first-degree relatives will modify the breast cancer risk for the PAL-B2 carrier. That's why you see this increase. The other aspect here is that, of course, the BI-RADS information was entered on this on this PAL-B2 carrier, and it's BI-RADS-C, which is increasing risk further. So, of course, this is another factor that seems to be increasing risk in this particular example. So this is explained, I would say.
Okay, no, that's super helpful. So one of the main messages, make sure you enter all the pedigree information, because that will help either increase or decrease, often decrease the risks that we might
affected, yeah.
Okay, perfect. All right, so those were the cases. I'm excited that we actually got through all of them. Thank you so much, Antonis. Just wanted to highlight our upcoming case conferences. In June, we have Joanne Kotsopoulos, who's going to be talking about hormonal risks in women with hereditary breast and ovarian cancer, which again, from a clinical standpoint, many of us have to deal with pretty frequently. And then in July, we have Dr. Elizabeth Swisher talking about clonal hematopoiesis in cancer survivors with inherited cancer. So excited about our upcoming case conferences. And again, you see we have a lineup of speakers scheduled for most of the remaining of the year. So thank you everyone for attending. Special thanks to Dr. Antonis Antoniou. As always, you don't disappoint. So this was a fantastic case conference, and we'll see everyone soon. Thank you.
Pleasure.